Hello, everybody, and welcome to a class on trauma of the spine and spinal cord, the anesthetic considerations. In 4,000 years ago in Egypt, patients were left bedridden, and they were first studied to have spinal cord disorders. Ellsberg in 1925 described the surgical treatment of spinal cord tumors. He is the person who established the first neurosurgery service in New York City. Ellsberg graduated from Columbia University College of Physicians and Surgeons in 1893, and after working in Mount Sinai Hospital, he spent 2 years in Breslau, Germany, working under general surgery under Jan Felix Radecki. He wrote the dispute between the surgical approach to penetrating spinal cord injury and the conservative one, and the attempts to regenerate the severed cord. Civilian versus military injuries with or without dural tear, complete versus incomplete damage, stable paralysis versus to slowly progressive improvement, and development of post-traumatic hematomylia. The care for the neurogenic bladder, the problem of root pains at the upper level of the spasticities, and the care for the neurogenic bladder. And the problem of root pains at the upper level of the lesion, if they cannot be relieved by immobilization of the spine by plaster jacket or other apparatus, may demand an operative interference, that is, decompressive laminectomy with division of the necessary posterior nerve roots. He is remembered as one of the foremost influential writers on spinal cord decompression. He described the indications and contraindications for laminectomy. He said that the primary indications for operations were cases of tumor, trauma, and infection that were associated with symptoms localized to spinal level. Patients with progressive symptoms were supposed to be operated quickly and in the absence of contraindications such as metastatic cancer or advanced Pott's disease. William V. Keene, Victor Horsley, Harvey Cushing, and Ellsberg were regarded as the pioneers in the removal of central nervous tumors. This is the anatomy of the spinal cord. That is the anterior view, the lateral view, and the posterior view. The vertebral column has 4 curves in the anteroposterior plane. The 2 forward curves are the lordosis, are present in the cervical and the lumbar areas. And the 2 posterior curves of the kyphosis are in the thoracic and the sacral areas. The combination of these curves gives a normal bony spine the characteristic S shape and is viewed from the side. The anterior longitudinal ligament and the posterior longitudinal ligament extend from the base of the skull and atlas to the sacrum. What are the spinal cords supported by? The ligaments contained by the spinal cord are the anterior ligament, which is attached to the anterior surface of the vertebra and the intervertebral disc. The posterior ligament is attached to the posterior surface of the vertebra and the intervertebral disc and lies within the vertebral canal. These 2 ligaments provide extension and flexion stability to the vertebral column. The supraspinal and interspinal ligaments join the spinous processes at each level, providing additional flexion stability. The ligamentum flavum unites the vertebral laminae at each level and forms part of the posterior border of the intervertebral foramen. If you can see here, these are the various parts of the spinal vertebrae. This is the superior articular facet, below is the inferior articular facet. It consists of the body, the pedicle, and the transverse process. And posteriorly, you can see the spinous process and an intervertebral foramen, which is surrounded by the bony parts of the spinal cord. The first 2 vertebrae, that is the C1 and C2, differ in structure from the standard vertebrae. C1, the atlas is ring-shaped and it is wider than the other vertebrae. The superior articular facets are configured to co-articulate with the 2 occipital condyles located at the base of the skull on either side of the foramen magnum. The atlas is composed of the anterior and posterior arches, and each possess a tubercle while sharing lateral masses. The atlas has no spinal process or body. C2, the axis processes a body that projects superiorly over here as the dens and a short bifid spinous process. The axis has 2 large, flat superior articular facets. The transverse ligament of the atlas holds the dens in place, and it prevents the horizontal movement of the atlas. This picture here describes the anatomy of the spinal cord. It consists of an anterior median fissure and a posterior median septum, an anterior funiculus, anterior rootlets, anterior root, as well as a spinal ganglion leading to the posterior root and a posterior funiculus. It consists of a central canal consists of an anterior gray column and posterior gray column, as well as an intermediate gray column. And surrounding it, you have the anterior white commissure and the posterior white commissure. This is the cord segment with its roots, ganglia, and branches. It consists of ventral rootlets, the primary ventral ramus, and a sympathetic chain ganglion. And in the dorsal root moves forward with the dorsal root ganglion and the primary dorsal ramus. The blood supply of the spinal cord is supplied by the single anterior spinal artery with two posterior spinal arteries. And it also consists of radicular arteries, which are twigs from the vertebral ascending cervical, posterior intercostal, and first lumbar arteries. These enter the vertebral canal via the intervertebral foramina. They give the anterior and posterior radicular branches that reach the surface of the spinal cord along the anterior and posterior roots of the spinal nerves. They form this circular anastomosis with branches of the spinal tracts. The spinal cord blood flow has been studied extensively in animal models. So the average spinal cord blood flow is about 60 ml per 100 grams per minute, and an 3-fold to 4-fold gray matter white matter differential in blood flow. The autoregulation in the cord, it mimics that of the brain, with a flow well maintained between a mean arterial pressure of 60 to 120 millimeters of mercury, as well as the arterial effects of the arterial blood gas tensions are similar to that of the brain. That is, hypoxemia and hypercapnia causes vasodilatation, and hypocapnia causes vasoconstriction. Injury to the spinal cord disturbs the autoregulation of blood flow. Trauma to the cord results in decrease in spinal cord blood flow and loss of autoregulatory function. And the nature of the operative procedure itself may have an effect on the spinal cord blood flow. This effect is well recognized with simple distraction and instrumentation, but may also occur during other operations such as simple laminectomy. Let's say a person has a spinal cord injury. What are the radiological investigations that one can do? This can be the plain radiography, that is X-rays, computer tomography, which is the CT angiography, MRI, MR angiography, bone scans, single photon emission computed tomography, and positron emission tomography. And the choice of the imaging modalities best suited for the patient depends on the history, the physical findings, and the differential diagnosis. Coming to the surgical disorders of the spinal cord. Cervical spondylosis. This is the degenerative disease of the cervical spine. 90% of individuals older than 65 years of age have this disorder. Cervical spondylosis refers to the non-specific degenerative process of the spine that may result in degenerative listhesis, spinal stenosis, as well as neural foraminal encroachment. Cervical radiculopathy is a neurological condition characterized by dysfunction of the cervical spinal nerve, the spinal roots, or both. It is most commonly caused by lateral disc herniation or osteophyte overgrowth of the narrowing of the lateral foramen, or cervical spinal instability caused by subluxation of a cervical vertebra. Here you can see cervical radiculopathy caused by foraminal stenosis from the posterolateral herniation of the nucleus pulposus with compression of the exiting nerve root. Cervical spondylotic myelopathy is the most common type of spinal cord dysfunction in patients older than 55 years. Originally, to describe more than 50 years ago, cervical spondylotic myelopathy is a result of narrowing of the spinal canal due to degenerative process of congenital disorder. The primary pathophysiologic abnormality in cervical spondylotic myelopathy is the reduction in the sagittal diameter of the spinal cord. Here, cervical myelopathy develops in nearly all patients in whom there is a greater than 30% reduction in the cross-sectional area of the cervical vertebral canal. A patient with cervical spondylotic myelopathy may have pain in the neck, shoulder, and subscapular areas, numbness or tingling in the upper extremities, motor weakness in the upper and lower extremities, sensory changes in the lower extremities, gait disturbances, bowel and bladder dysfunction and spasticity, hyperreflexia, and conus typical of an upper motor neuron lesion. The treatment of cervical spondylotic myelopathy initially involves non-operative therapy. However, early surgery is associated with significant improvement in the neurological processes. If surgical intervention is chosen, then they may do any of the four following surgical procedures, which is the anterior cervical discectomy and fusion, that is the ACDF, anterior cervical fusion, that is the ACF, cervical laminoplasty, and posterior cervical decompression and fusion. This diagram demonstrates the common sites of pathology that may result in compression of the spinal cord or the nerve root. That is a lateral disc herniation or the osteophyte hypertrophy, central disc herniation, the facet joint osteophyte, and hypertrophy of the ligamentum flavum. So coming to the anesthetic management of a patient with cervical spine, we should consider the specific technique that is most appropriate for securing the airway, the choice of the anesthetic agents, the hemodynamic monitoring, and the use of vasoactive medications and positioning. For patients with symptomatic spinal stenosis, we can use awake fibroctomy intubation, but initial induction of anesthesia followed by fibrotic intubation using manual inline stabilization with or without spinal cord monitoring is a viable option. We can use invasive blood pressure monitoring to facilitate the maintenance of adequate spinal cord perfusion. We should maintain the mean artery pressure greater than 85 millimeters of mercury. And if electrophysiologic spinal cord monitoring is planned, the anesthetic strategy should select the agents with the minimal effects on the electrophysiologic waveform potentials. The decision to extubate the patient following surgery should be made only in the absence of any airway edema, neck hematoma, and the depressed mental status. In cervical spine, the most common location of herniation is at C5, C6, followed by C6, 7. And herniation is most commonly in individuals greater than 40 years. The symptoms of cervical disc herniation are neck pain and radicular symptoms, which consist of shoulder, arm, or hand paresthesias or pain, and muscle weakness and a dermatomal nerve root distribution. Patients may also present with symptoms of cervical myelopathy if the herniation is centrally located. In patients with whom disc herniation is suspected, plain films may demonstrate a narrowed disc space, osteophytes, or subluxation of the vertebra. An MRI is a radiological imaging modality of choice for evaluation of a suspected herniated cervical disc. So, medical management of a cervical disc herniation can involve cervical soft collars, anti-inflammatory agents, oral steroids, and physical therapy. And 90% of these patients with radiculopathic symptoms experience improvement with all of these measures. If non-surgical therapy fails, then we can move on to surgical therapy such as ACDF with or without anterior cervical plating. Now, what complications can occur following a cervical disc surgery? The patient may have thoracic disc injury, so CSF leak, spinal cord and nerve root injury, vertebral artery injury, perforation of the esophagus or trachea, recurrent laryngeal nerve injury, postoperative hematoma, and wound infection. In cases when there is significant postoperative hematoma, the airway should be left secure until the patient is fully awake, the hematoma is not enlarging, and there is a tracheal cuff leak. Coming to syringomyelia. Syringomyelia is a cystic cavitation of the spinal cord. There are two types that have been described, that is syringomyelia and hydromyelia. In hydromyelia, there is primary dilatation of the central canal that is often associated with abnormalities in the foramen magnum, such as Chiari malformation, which is tonsillar herniation, and basal arachnoiditis. In true syringomyelia, a cyst is present within the spinal cord substance itself, and it does not communicate with the central canal or the subarachnoid space. The common causes of true syringomyelia are trauma, neoplasm, and arachnoiditis. And typically, an adult between the ages of 20 and 50 years who complains of sensory loss in a cape distribution, that is cervical or occipital pain, wasting in the hands, and painless arthropathies. MRI is the investigation of choice, and it should have images of the cervical and the thoracic spinal cord as well as the brain. The treatment should focus on re-establishing normal CSF flow across the site of injury. The choices for therapy include a posterior fossa decompression and C1 laminectomy. And the presence of a Chiari malformation, that is fenestration of associated arachnoidal cyst, resection of an associated neoplasm, or placement of a shunt with direct drainage of the cyst into the subarachnoid space or pleural cavity. The airway management of patients with syringomyelia should consider the neurological deficits commonly associated with disease. In a patient with syringomyelia and Chiari malformation, there is limitation of neck flexion and extension is necessary in order to prevent further compression of neuronal structures. The limitation of neck motion during intubation by the use of fibrotic bronchoscopy, either awake or after induction, is an appropriate choice. Coming to the disorders of the thoracic and the lumbar spine, there is a herniated disc which occurs most commonly at the TA to T12 with peak incidence between the ages of 40 to 60 years. The majority of the disc herniations are located laterally, and the patient may have symptoms such as pain, myelopathy, sensory disturbances, and bladder dysfunction. The lumbar disc herniation is very common, which occurs in 22% of the general population and can be associated with a phenomenon known as sciatica, which is the most common cause of radicular leg pain in adult working population. For most people, sciatica typically resolves within 2 months of the onsets in patients who are treated medically, and surgery is rarely necessary. And majority of the lumbar herniations occur the L4, L5 or L5S1 spinal levels because most often they have the herniations posterolaterally, but the posterior longitudinal ligament is thinnest. If a patient has a centrally located disc herniation, the cauda equina syndrome may occur. This is a syndrome consisting of lower back pain, bilateral lower extremity sensory motor deficits, bladder dysfunction, sexual dysfunction, perirectal sensory loss. So if a person has cauda equina syndrome, it warrants urgent medical attention, and MRI is the imaging modality of choice. The reasons why the patient will require surgical therapy is when the patient develops cauda equina syndrome, significant motor deficits, severe pain unresponsive to medical therapy, failure of conservative therapy after 2 to 3 months, and large extruded disc fragments. The surgical options can include the discectomy, spinal fusion, hemilaminectomy, and/or laminectomy. Coming to the anesthetic management, we should consider the presence of pre-surgical neurological deficits, requirement of a meticulous positioning technique, identification of comorbidities that may increase the risk of complications, and the amount of anticipated blood loss. Invasive blood pressure monitoring is appropriate in patients with serious comorbidities, and non-invasive blood pressure monitoring is usually adequate in otherwise healthy patients scheduled for a lumbar procedure for disc herniation. Here you can see the lumbar disc herniation. This is the T2 weighted MRI showing a large disc herniation at the L4, L5 with the nucleus pulposus extending 2 centimeters cephalad into the ventral epidural space. Lumbar spondylosis is a term referring to changes in the vertebral joint characterized by progressive degeneration of the intervertebral disc, with subsequent changes in the bones and the soft tissues. And the characteristic pathological changes that can occur are degeneration, ligamentous and facet hypertrophy, spinal stenosis, and spondylolisthesis. A clinical spectrum of spondylosis includes spinal instability, spinal stenosis, and degenerative spondylolisthesis. Lumbar spinal stenosis, it occurs most commonly at the L4, L5 spinal level, followed by the L3, L4 level. And a patient with congenitally short pedicles typically have a shallow spinal canal. This predisposes them to spinal stenosis later in life because the typical degenerative changes in the spine occur, such as disc protrusion, facet joint degeneration and hypertrophy, ligamentous hypertrophy, and spondylolisthesis. The clinical symptoms of lumbar spinal stenosis include the gradual onset of leg and buttock pain combined with lower extremity sensory neural deficits. These symptoms may progress over a period of months. Spondylolisthesis is a term referring to the anterior displacement of one vertebra on another associated with degenerative changes in the presence of an intact neural arch. This may be congenital or acquired. Women are affected 4 to 6 times more than men. And the development of spondylolisthesis is associated with the presence of degenerative intervertebral disc, laxity of ligaments, and facet joint pathology. Here you have the slipped vertebra, which is the spondylolisthesis. Thank you.